Hello everyone and welcome to this online course on electrocardiogram. I am Dr. Anbarasi, Professor of Physiology from Chettinad Hospital and Research Institute. In this very first video lecture, we are going to see about the basic conduction of the heart. This is very important in understanding the principles of electrocardiography. In this lecture, I am going to take you all through the functional anatomy of the conducting system of the heart, the role of gap junctions, the various cardiac potentials, namely the pacemaker potential and the ventricular action potential, how this wave of excitation is spread to the entire myocardium, and then and there we will be seeing about the control of excitation and conduction in the heart. In the first section, we are going to see about the conducting system of the heart. This is nothing but the electrical pathway that lead on to atrial and the ventricular contraction. The electrical activity is produced by one group of cells that leads on to the mechanical phenomenon, that is your ventricular muscle contraction. Now, the cardiac cells are classified based on the function as well as based on the speed of conduction. Based on the function, the cardiac cells are classified as pacemaker cells and contractile cells. The SA node, AV node, bundle of His and its branches and the Purkinje fiber system forms the pacemaker cells, whereas the atrial and the ventricular cardiac myocytes form the contractile cells. Based on the speed of conduction, the cardiac cells are classified as slow fibers and fast fibers. The SA node and the AV node are the slow fibers, whereas the Purkinje fiber system, atrial and the ventricular myocytes are the fast conducting fibers. In this picture, we are seeing the conducting system of the heart. You can see here, this is a structure present in the roof of the right atrium. This is the SA node. There is another structure in the floor of the right atrium which is called as the AV node. These two structures are connected to each other by means of three internodal tracts, the anterior, middle and the posterior internodal tract. Also, a branch of the anterior internodal tract also goes to the left atrium to excite the left atrium. The AV node continues as His bundle, which very soon branches into right branch and the left branch. The left branch again branches into anterior fascicle and the posterior fascicle. Both the branches, they go and merge with the Purkinje fiber system. This is the conducting system of the heart. Now, let us see the pacemakers of the heart. What is this pacemaking activity? This is nothing but the spontaneous time-dependent depolarization of the cell membrane that may lead on to an action potential in an otherwise quiescent resting cell. The word time-dependent is very important here because this depolarization occurs at a regular intervals, and this regular interval or spacing is the one which is deciding the rhythm of the heartbeat. Now, there are different cells, pacemaker cells in the heart. The fastest pacemaker is usually setting the heart rate. The fastest pacemaker is the one which has got the highest frequency. So, in that order, if we can see, the SA node, the sinoatrial node has got the frequency of 60 to 100 beats per minute. This is the primary pacemaker of the heart. Next is the AV node, has got the frequency of 40 to 60 beats per minute, which is followed by the Purkinje fibers, which is capable of producing the electrical activity at a rate of 20 to 40 beats per minute. Let us see the sinoatrial node. It is located at the wall of the right atrium, just below and to the right of the opening of superior vena cava. When compared to the entire heart, this SA node forms the smallest electrical region, but this has got the fastest pacemaking activity at a rate of 60 to 100 beats per minute. The rhythm produced by the SA node is called as normal sinus rhythm. Now, this inherent or intrinsic pacemaker activity, also called as automaticity or autorhythmicity, is subjected to sympathetic and parasympathetic influence. The sympathetic activity increases the automaticity by acting on the beta receptors, whereas the parasympathetic activity decreases the SA nodal activity by acting on the muscarinic 2, that is M2 receptors. Also, this SA nodal cells or the targets for the therapeutic agents which try to modulate the heart rhythm. For example, the calcium channel blockers, beta adrenergic blockers act on the channels present in these SA nodal cells to modulate the heart rate. Next, we will see about the internodal tracts of impulse conduction. As we saw in the previous picture, the SA node generates the pacemaker potentials which will be carried to the AV node via these three internodal tracts, the anterior or Bachmann's, middle or Wenckebach, posterior or Thorel's bundle. Apart from that, a branch of Bachmann's bundle also reaches the left atrium to excite the left atrial tissues. Now, apart from these physiological internodal tracts, the general excitation can also spread from cell to cell in the atrium via a specialized structure called as the gap junctions. Next in the order of conducting system is the atrioventricular node, which is located in the antero-inferior part of the interatrial septum above the opening of coronary sinus. This particular area is called as triangle of Koch. Compared to the SA node, this AV node has got fewer pacemaker cells, and this also continues as the bundle of His. The main function of this AV node is that it acts as a reserve pacemaker, that is, when the SA node fails, this AV node will take up its position of pacemaker, and this conducts the action potential from the atria to the ventricles in an unidirectional way. This also mediates a very important phenomenon called as AV nodal delay, which we will be discussing shortly. Next, the AV node continues as the bundle of His and which merges into the Purkinje system of fibers. This bundle of His branch into right branch and the left branch. The left branch once again branch into anterosuperior fascicle and posterior-inferior fascicle. The right branch supplies the entire right ventricle, whereas the anterosuperior fascicle supplies the anterior wall of the left ventricle and posterior-inferior fascicle supplies the posterior wall of the left ventricle. In the next section, we are going to see about the cardiac muscle and its properties. Like skeletal muscle, cardiac muscle is also a striated muscle with nucleus and many active mitochondria. But then the cardiac cells, they branch and interdigitate. The most important feature of the cardiac muscle is that the adjacent cardiac muscles, they are united by means of a special structure called as intercalated disc. This is the intercalated disc. See, this is the histological picture of the cardiac muscle, the adjacent muscles. When you expand, here you can see the adjacent plasma membrane of the adjacent cardiac cells. They approximate each other and forming this specialized structure called as intercalated disc. Now, when the SA node is generating the action potential, the wave of depolarization is spread from one cell to another via the intercalated disc. You can see the intercalated disc is actually the plasma membrane which lie in close proximity with the adjacent cell's plasma membrane. They are bound tightly by means of this desmosomes. This is the desmosome. Okay. And then in the area where the plasma membranes approximate each other, there is a special channel called as gap junctions, which are the low resistance bridges across which the electrical current flow from one cell to another cell. Consider the cells A, B, C and D are all the adjacent myocardial cells bound to each other by means of this gap junctions, this yellow structure. Okay. And you can see the cells are all in the resting stage as is denoted by the negative ions lining the interior of the cell while positive ions are lining the exterior of the cell. There are membrane channels present in the cells which can conduct the positive ions. Now, when the cell A is excited, what happens? A wave of depolarization will spread from A to B. This will cause increase in the positivity in the cell B, which will open up the membrane channels and positive ions flow into the cell B. This will further enhance the positivity or depolarization in the cell B, which will be conducted from B to C via the gap junctions. Okay. And the cell C will now have increased depolarization in it. This wave of current of depolarization from B to C is called as intracellular current. Now, the same intracellular current will flow from cell C to cell D. Not only it goes in that direction, but it also displaces some of the positive ions attached to the cell membrane in the cell D, and that is called as capacitance current. Now, this positive ions will flow from cell C back to cell B in the opposite direction. This is called as extracellular current. So, whenever there is an intracellular current flowing from one cell to another, an equivalent and opposite extracellular current will be flowing in the reverse direction. The flow of this extracellular current in the heart gives rise to an instantaneous vector in the heart, and this changes with time. ECG is nothing but the sum of all these electrical vectors which are recorded at one particular plane and at one particular time. So, the cardiac muscle fibers are actually they connected to each other in series and parallel. Their membranes form the intercalated disc which has got the gap junctions across which the current freely flows from one cell to another in one direction, and hence when one cell is excited, the action potential can easily spread through the gap junctions. That is how when one cardiac cell is excited, the entire cardiac muscle will act like a syncytium, and that is in a unitary fashion. Okay. In fact, we have got one atrial syncytium and one ventricular syncytium. That is the importance of this gap junctions. Coming to the properties of the cardiac muscle, they are excitability or bathmotropism, conductivity or dromotropism, contractility or ionotropism, and rhythmicity or chronotropism. Along with that, we have got a special feature of refractory period. Now, with respect to ECG, the first two properties, that is the excitability and conductivity, are very important, and we will discuss about that. Excitability is nothing but the ability of the cardiac tissue to respond to stimuli by producing an action potential. So, in that way, there are two types of cardiac tissues, excitable cardiac tissues, which are conducting tissue, which is producing a pacemaker potential. Example is the SA node. Other one is a contractile tissue which produces a true action potential as seen in the ventricular myocardium. What is this pacemaker potential? Here spontaneous time dependent depolarization occurs, but the pacemaker cells show an unstable resting membrane potential. The resting membrane potential ranges from -65 to -55 millivolts. Now, why this resting membrane potential is unstable? Because there is slow rise of the resting membrane potential because of the slow depolarization. This rising phase of the resting membrane potential is called as prepotential. So, when it rises slowly and when it reaches -40 millivolts, this is the firing level, a rapid depolarization will occur which goes up to +5 millivolts, which will be followed by rapid repolarization. This completes one action potential in a pacemaker tissue. You can see here in this picture, SA nodal potential is depicted. You can see the slope of rising depolarization from -60 gradually, it goes up to -40. When it reaches -40, that is at firing level, it throws a depolarization which will be followed by a repolarization, and again the resting membrane potential is unstable. It keeps on increasing until it reaches the next level, next cycle, that is -40 millivolts. The same similar picture is shown in the AV node. Now, this slow rise in the depolarization is called as prepotential. What is the ionic basis of this prepotential? This happens at the end of repolarization or sometimes hyperpolarization. That is why it is called as IH, that is hyperpolarizing currents. Now, what happens during the first half or early phases of this prepotential? The potassium efflux is decreased. The conductance of the potassium through the potassium channels, it is decreased. Also, there occurs opening up of one particular type of channels called as leaky sodium channels, or it is otherwise called as funny channels, because it allows both the sodium ions and potassium ions. So, because of that, there is slow entry of the positive ion, maybe sodium ion, that leads to slow rise in the depolarization. The later half of the prepotential is because of opening up of transient type of calcium channels, and calcium influx. Once it reaches minus 40 millivolts, another type of calcium channels is open, that is long lasting calcium channels, and there will be rapid inflow of calcium ions. Remember, the SA nodal potential and the AV nodal potential, the depolarization is because of opening up of calcium channels. Sodium channels has no role in pacemaker potential. So, the unstable RMP, the early part is due to the hyperpolarizing currents as well as the funny currents, and the later part is because of T-type calcium channels. Rapid depolarization is because of L-type calcium channels, and repolarization is because of potassium efflux. Look at this picture which shows the regulation of the pacemaker activity by the sympathetic and parasympathetic activation. See, this is the normal rhythm of the pacemaker tissue. When there is sympathetic stimulation, look at the slope of this prepotential, it is increased. Now, why this occurs is the noradrenaline produced in the sympathetic nerves, they act via the beta 1 receptors, it increases the intracellular cyclic AMP, this will open up the L-type calcium channels. So, rapidly this depolarization will take place, that is why the slope is increased, okay, and the heart rate is also increased. Now, look at the vagal stimulation, look at the slope here, slope of the prepotential is decreased. Here the acetylcholine released at the vagal nerves increases the potassium conductance and slows the hyperpolarizing currents. Also, via the M2 receptors, it delays the opening up of the calcium channels. So, that is how it delays the next impulse. So, this decreases the slope of the prepotential and hence decreases the heart rate. Next, we will see about the contractile tissue potential, see the atrial muscle as well as the ventricular muscle. The one important feature that you should notice is, look at the resting membrane potential, it is a stable resting membrane potential ranging from minus 85 to minus 90 millivolts. Okay. So, it is the baseline is a straight line, it is not a slope unlike we saw in the pacemaker potential, which will be followed by a rapid rise or a straight depolarization which crosses zero potential, and then there will be a short repolarization which is followed by a plateau, and then a regular repolarization occurs until it reaches the resting membrane potential level. Now, this Purkinje fiber is almost similar to the ventricular muscle in terms of the electrical activity, but the only difference is, look at the resting membrane potential. This is a pacemaker tissue, so this shows the unstable resting membrane potential, you can see the slope, whereas in ventricular muscle it is stable, it is a straight line here. But similar to the ventricular muscle, this has also got a straight line denoting the depolarization, that is rapid depolarization, an initial rapid repolarization followed by a plateau and then the slow repolarization. This is because in Purkinje fibers, the depolarization involves both the sodium channels as well as the calcium channels, whereas in the pacemaker tissue, the depolarization is only because of the calcium channels. So, the contractile tissue action potential is created by the fast fibers, especially the ventricular and the atrial fibers. Resting membrane potential is stable and it has got various phases as is depicted in this picture. Phase 0 is the rapid depolarization, this is because of the sodium currents. Then phase 1 will be the initial rapid repolarization, this is because of the closure of the sodium channels as well as opening up of the calcium channels. There will be a plateau phase, that is phase 2, which is done by the slow influx of the calcium ions, which will be followed by the repolarization phase 3 and back to the resting membrane potential phase 4. Summary of the ionic basis of cardiac action potential, phase 0 is because of the sodium influx through the voltage gated sodium channels. There will be some influx of calcium ions via the slow calcium sodium channels also. Phase 1 will be because of closure of the sodium channels and opening up of specific type of potassium channels called as ITO, that is transient outward currents of potassium. Phase 2 is because of the slow influx of the calcium channels through the calcium ions through the calcium channels, and also slow efflux of the potassium ions. So, the membrane potential does not change, it remains a plateau. Phase 3 and phase 4 is because of the efflux of the potassium ions through various types of potassium channels. The next important property is that the conductivity. This is nothing but the ability to conduct an action potential by sequential depolarization of the adjacent cells. How the action potential is conducted from one cell to another. Almost all the cells are capable of this property, that is conductivity, only that the conduction velocity differs. For example, the SA node and the AV node are the slowest conducting fibers with a velocity of 0.05 meter per second. Purkinje fiber system is the fastest conducting system in the heart with a velocity of 4 meter per second. Atrium, ventricle and bundle of His, they conduct at a velocity of 1 meter per second. This is the conduction pathway. As we all know, SA node generates the potential, it transmits to the AV node via the internodal tract to the right atrium and via a branch of anterior internodal tract to the left atrium. So, within this 0.1 second, the entire right atrium and the left atrium is excited. Okay. And then when the impulse comes to the AV node, there will be a delay of about 0.1 second in the AV node. Then the impulses crosses the AV node, goes to the bundle of His, its branches and then reaches the Purkinje system to excite the entire ventricular myocardium. So, this takes around 0.08 to 0.1 second. So, within approximately 0.3 second, the entire heart, atria and the ventricle gets excited once the pacemaker potential is generated. Now, what is this AV nodal delay? This is one important phenomenon happening in the AV node. Here, the conduction of the rapid impulses will be delayed for about 0.1 second in the AV node. This is called as detrimental contraction. The reason for this delay is that the transitional fibers which connect the internodal tracts to the AV node are very small and they have very slow conduction velocity, even less than the SA node and the AV node, say for example 0.02 to 0.05 meter per second. And they also have very few gap junctions. We know that the atria and the ventricle are separated by a fibrous ring of tissue, and this AV node and the bundle of His and its branches are the only way to transmit the impulses. Okay. And the advantage of this AV nodal delay is that because of this delay only, the atrium is able to completely contract and empty its blood into the ventricle before the ventricular contraction stops. So, a sufficient amount of cardiac output is possible only because of this AV nodal delay. Now, this AV nodal delay is also shortened by the sympathetic stimulation and lengthened by the parasympathetic stimulation. So, once again this picture showing the SA node, AV node conduction occurs through the internodal tracts, and from the AV node bundle of His continues. It runs for a short distance in the septum, upper part of the septum, divides into right branch and the left branch. The left branch again divides into anterior fascicle and the posterior fascicle, and both the branches run down the septum and merges with the Purkinje fiber system. Now, how this excitation wave spreads? We will see in this picture. This is the beginning of the atrial excitation, which is the excitation produced in the SA node is travelling towards the AV node. And in this picture, as shown in this yellowish coloration, both the right atrium and the left atrium is excited. That means atrial excitation is complete. You can see the recording of this action potential here in the bottom picture. When the atrium started its impulse generation, a slight upward deflection has started, and when both the atrium are conducted, there is a complete one positive wave. This wave is the P wave of ECG. Next, the ventricle is getting excited. So, when the impulse comes to the bundle of His, which is present in the top of the septum, it goes towards the left side little bit, and then in the mid of the septum it turns towards the right side, and the spread of excitation goes downwards towards the apex of the ventricle and then turns upwards on either side towards the AV groove. So, that is how the complete ventricular myocardium gets excited. You can see during the septal activation, there is a formation of some negative wave which will be followed by a positive wave, and then when the ventricular excitation is complete, you can see three waveforms: Q wave, R wave and S wave. Together we call it as QRS complex, that is denoting the ventricular excitation. This excitation spreads from endocardium to epicardium, that is very important. Now next is the ventricular relaxation, which is occurring from epicardium to endocardium, and that forms another positive wave called as T wave. So once the depolarization comes to the AV node and goes to the bundle of His, it starts at the left side of the septum and moves to the right across the mid portion of the septum. Then the excitation spreads down the septum to the apex and turns along the walls of the ventricles on both sides, right and left side, and goes towards the AV groove from the endocardium to the epicardial surface. The last portion of the heart to get excited is the posterior-basal portion of the left ventricle, the pulmonary conus and the uppermost part of the septum. This is how the spread of excitation takes place. So this is a picture showing the depolarization or the action potential produced at different parts of the conducting system. So this is the SA nodal potential, you can see here, then is the atrial muscle, then the AV node, then the His bundle, its branches, Purkinje fiber system, finally the ventricular muscle. Now ECG is nothing but the sum of all these action potential at any given time and any given plane. So this electrical vector of all the action potentials produced in different conducting systems of the heart gives rise to ECG and its various waveforms, namely P wave, QRS complex, T wave and U wave. Summarizing the entire content, we have seen that the conducting system of the heart includes the cardiac cells classified as different ways based on the function as pacemaker cells and the contractile cells, and based on the speed of conduction as slow fibers and fast fibers. Pacemaker cells are SA node, AV node, bundle of His branches, Purkinje fibers. Contractile cells are atrial and the ventricular myocytes. Slow fibers are SA node and AV node, whereas other cells are fast fibers. Next we saw about the production of this extracellular current, that is when the action potential or when the wave of depolarization spreads from one cell to another cell as intracellular current, an equivalent wave of depolarization will spread in the opposite direction. This forms the extracellular electrical vector, and the ECG is nothing but sum of all these electrical vectors recorded at one particular plane at one particular point. Then we saw that the conduction pathway is complete within 0.3 seconds since its origin at SA node, and there is a delay of this 0.1 second in the AV node, which is actually beneficial for producing a better cardiac output and better contraction. Now we also saw that how the wave of excitation spreads across the different parts of the conducting tissue, starting from the SA node, and then the entire atrium, right and the left atrium gets excited, that leads on to a positive wave, that is P wave. Then comes the wave of excitation along the septum and the ventricle muscle, and that completes the QRS complex, followed by the ventricular relaxation, which gives rise to the T wave. This is a picture finally showing the electrical activity, that is depolarization and repolarization pattern in different parts of the conducting system, right from the SA node till the ventricular muscle, and the sum of all these electrical activity in terms of action potential is recorded as different waveforms of ECG. So we will be discussing about a lot more about ECG in the further lectures. I thank our University Chettinad Academy of Research and Education and NPTEL for enabling this course to the viewers. Thank you.